What I would say is that every day we are still working on this, and we're not here to tell you we've got it all sorted, because I think no one would believe us. But what this is about is holding to a frame that assists you every day to make the decisions that you need to make about how you're improving care at your health service. And I think that's what this whole framework has helped us to be able to do. So one of the things that I'll come back to this slide, because this is really about a lot of the things that we were struggling with at the time. But we knew we needed to improve the patient experience, and we knew we needed to kind of get there. What this slide is really about for me when I first got there was that we had misalignment across all of these components. The data people were doing great data work, and the frontline staff were thinking about that, and the DONs were running around trying to make kind of changing clinical practice for nursing at the front line, and the medical staff were doing something, but it was going on in a whole lot of different places. Lots of people, incredible energy, incredible commitment within the organisation, but people were doing stuff in isolation of a whole kind of idea. Again, it's surprising, because I know you've all just sat through that pretty straightforward process, but we hadn't really defined what it was that we were wanting to achieve as an organisation, what it was to achieve what we call best care at our place. So, we knew that we had problems around accountability, and people had lack of clarity in all parts of the organisation. So we started doing the process, and we started defining what we call best care. I knew I was getting lost back into the complexity. I was going to have policies and procedures and enablers and pillars, and how you kind of start getting in that, and you kind of think, yeah, well, then I've got to have an IT system that supports it, and you get very, very complex. And what had happened was, I couldn't find the voice of best care. I couldn't find where to land it without making it another complex clinical governance framework. So we've done all that, we're pretty clear about what we wanted to do, but then to make that happen started to get very, very complex in our minds, and very much templated on our past. We had systems in place, of course, we're like any health service. We had a whole lot of things going on, and we had a whole lot of ways that we could template that idea back into our history. And in Victoria, we have a thing called open access board meetings. I'm sure other people have various circumstances of the same thing, but ours at Western Health are actually incredibly engaging, if I could put it that way. And a group of patients started saying, and I think your table started it, we want to be seen and treated as a person. And they kept on saying it to us. I want to be seen and treated as a person. And the minute that voice started speaking in the best care strategy, it cascaded the best care strategy right back up, and we could build off that first person voice. So that's what started to occur to me, and that's when I went to Cathy and I said, I think we can do this in the first person, because I'm worried about the accountability in the organisation. I'm worried about that we haven't clearly told to consumers and their families what they can expect from us, that we haven't owned that commitment about their expectations and how we're going to deliver it. And so we started forming the ideas into the first person, and it was like the whole thing then started to shift for us. And what we come up with is we came up with the best care strategy, and honestly, it is that in that. You'll see it as you start reading through it. So the patients started to say to me, I'm seen and treated as a person. I receive, and we started to get the patient voice, went to focus groups and talking to them and a whole lot of stuff. I receive help, treatment and information when I need it and in a coordinated way. I receive care that makes me feel better. We know we can't make everyone better, but we can at least make them feel better during that journey. Good palliative care programs, those sort of things. I think you've got to be thoughtful about how you think that through. And I'll come back to I feel safe, because we could not get a patient to say that. I could not shake that out of one focus group, one one-on-one interaction, because the patients at Western Health, it had never occurred to them they weren't going to be safe when we started doing this. But if I didn't have I feel safe, you can imagine I don't have a safe domain in this. I need a safe domain because I need to be able to put deteriorated patient and all that sort of stuff into somewhere. So It was interesting. We could not shake any sense in our community about safety. So then we said to ourselves, okay, if they want to feel that, then what does a frontline staff member need to think about to support that? And what do they have to own? What do they have to actually be? So I communicate with patients and their families and am sensitive to their needs and preferences. I am an active team player and look for ways to do things better. I am competent in what I do and motivated to provide the best care and services possible. I keep patients from harm. And as you go through this, these are the 4 groups of staff that we think are integrally, part of the organisation. You go through managers and senior clinicians, all reflecting to support the statement, and you get to the top. And the board and the executive make a commitment to overseeing and supporting it in the way we just talked about over on that side. And once we started talking to the organisation about, okay, so if that's what we're saying, and you've got to get up and be able to say that you are delivering that you are committed and doing that, what does it mean we need to put around you? And that's then when we started to integrate it across the organisation. But it was finding that level of commitment and accountability in the first person voice that started to bring this whole thing into line with us. So I start orientation with new starts. And at orientation with new starts, I say there are 6,500 of us here at Western Health, and we are all here to create the best experience between the patient and the clinician at the front line. All of us. Because if that's not what a health service is trying to do, what on earth are we... I can't understand. What else could a health service be wanting to do? That it can only be about creating the best possible personal as well as clinical experience at that interface. Now that means a whole lot of us have got to do our work and do our jobs properly, but that's what we drive for every day. And the hard bit is every time. Because we do know, I think most of you here would be knowing that, I'm sure you all, consistency is actually probably one of the biggest challenges across the system. So I talk to the new starts and I say, you've been employed, you'll be performance managed, and you will also be performance managed determination as part of the best care strategy. It is a fundamental part of what you're doing here. My CFO every year, when he comes into his performance agreement with me, has to explain what he's done to support best care this year. I promise you, the first time Mark had to come in and do that, he looked at me as if to say, Alex, what are you talking about? I do finance. I do finance. I go, yeah, okay, you do finance, but what clinical teams have you helped to do redesign and move their resources around to create a business case that's improved a clinical outcome? Oh, that's what you mean about my job in best care. Yeah, that's your job in best care, is to support the clinical teams to have the resources to make the decisions and make the care that they need to do. Our PSAs, our cleaners and stuff, can talk to you about what they're doing in best care. Now, that's the aim, is to get everybody focused on that pointy little end down the front. But what we had to do was we had to kind of move the strategic plan to support it. We've got a whole lot of stuff where it comes through the business plans. So the business plans for every unit is reflecting both what the best care strategies are as part of the overall strategic plan. Performance plans have it in. The education team, I was very blessed. Louise was my director of education. We gave her the challenge. We said, can you take education and now reflect best care into it? She said, sure, Alex, that's easy. But within months, all of the education program had reverted over to supporting best care and supporting every bit of, every clinical nurse educator, all the kind of programs we're supporting. HR did all the stuff with policies, everything we had to do with personnel, and we cascaded it right down the system to an individual level as well to the meta level. Now that's the stuff we do. That's not what a frontline worker needs to know about. That's my job, and that's our job up in the leadership group. So that's how the leadership group could absolutely create that environment. We created exec sponsors to the 4 components. So person-centred care, you can imagine, comes out of the first statement. Coordinated care comes out of the second. We call it right care, which is appropriateness and effectiveness, but we do call it right care. And that's really resonated with people. It's something that clinicians really like. That's where all the clinical practice guidelines, all of those sort of stuff go through. And then, of course, we had to create safe care. And safe care takes, the standards that you can expect. We knew as an organisation that one of our outcomes of this was we had to meet the standards and we had to meet accreditation. That's something we have to do. But it is not the vision and the drive of this strategy. This is culture change. This is an organisational approach to delivering that interaction at the front line. Standards are just one of the KPIs that sort of sit at the end of it. And I think that was one of the things that I was so, when I first read those standards, like many of you, they're great. The standards are fine. I've got no problem with the standards. But if they are all we are doing, we are completely missing what it is to deliver excellent care to your relative in Beijing or best care at Western Health. So I just wanted to give you a bit of a sense of where we started. One of the things that was very tricky in this was that I started the process. I got that first sheet up, and then unfortunately, unfortunately, I don't know, kind of probably led to other discussions. I was unwell for about 2 months, and I went offline for a period of time. And when I went offline, I came back, and my team, as well-meaning as they were, had created, it was all about committees. I got back and they were all fighting about which committee it was and who was on committees and what the terms of references were for the committees and all of that stuff. And so I'm going to come back to lessons learnt later, but one of the things that you have to hold, and if you're in a leadership role in any part of this, it's really hard, is you have to keep it simple. Because the desire in health to overcomplicate things is just phenomenal. We work in a complex system. We ask our staff to deal with complex issues. If we then create a complex operational system that sits around them, we've got no hope. If you cannot keep it simple for the front line, who are needing to focus on so many things, if you can't give them clarity of purpose at the front line, that is pretty straightforward. I think that's the reason why so many of my previous clinical governance frameworks have failed. You know, we love the complexity. So complex passion, you create a complex system, you've then kind of created something that just can't move forward. And it gets to be quicksand, and your staff quickly get into that quicksand. So when I came back, it was extraordinary. I kind of had to come back from leave, and politely, because other people have been working hard and doing all sorts of stuff over the summer, he said, look guys, we've got to strip it back again. Because what you're doing is you're doing the spaghetti road thing, right? The temptation to go back spaghetti road in quality systems is phenomenal. So what Louise is going to start talking about is the kind of really practical ways in which we started to put on the ground. But as I say, we're going to talk about some of them, but I guess there's a comprehensive, I don't think you could think of anything that, engineering know what they're doing with best care. Everyone is in, the whole system has been focused around delivering this to the front line. Does that make sense? Yeah, Bernie.
How did you engage the medical staff in this? What did you do?
One of the things I think about the medical staff is that I long ago got my head around the fact that you engage them in the things of which their skill set and their input is highly focused and seriously needed, right? So honestly, I don't get them too involved with, 40 million committees and lots of policy and all of those things. I get them involved, they're very involved in right care. So right care does all the Dr. Foster data, HRT data for us, takes all our kind of clinical benchmarking and stuff. They're very engaged in that and creating up all sorts of, new pathways around a number of things. They're engaged in coordinated care where needed. The geriatricians are very engaged in person-centred care, particularly around things like falls and pressure injuries and those things. But I think you've got to go to them with things that you need their input on. So sitting around a lot of standing committees, I think most people would say with medical staff it's kind of pointless. So that was one thing, is we kind of, through best care, we could engage them in the bits that I think, and all the senior clinicians actually are, I'm talking about the doctors, but this was the same for all the clinicians, is they are engaged at the point of care questions, at the clinical guidelines, clinical decision-making questions. And they respond to that. It's in all their PDPs and stuff now. Like, I mean, it's integrated into their whole performance network and their credentialing and their re-credentialing and their scope of practice is all kind of best cared as well. So technically we've got governance around it as well. I think the other thing is that for the first time probably in the organisation now, we're hearing people talking solidly about the clinician and the patient at the front line is what we're working to deliver. And so when they come and have a conversation with me about the resources up the other end or something, you know, business cases and stuff, they know that's our end outcome and that's what we're focusing on. So I think they felt that we were focused on the right stuff, if that makes sense. They took the vision, they took the kind of meaning of what we were trying to do, and they supported the fact that we were trying to drive to the front line. One of my tests on that was we have a best care committee. Louise and I spend a lot of time on its agenda to make sure it's not boring as all get out, I'll say, rather than anything rude. Because, you know, those kind of committees start talking about policy and, you know, like everyone's shoulders go down and they think, oh my God, what are we doing here? So I make sure there's like at least 2 or 3 clinical decisions on every agenda. So that, but what was interesting was we put up an EOI for the clinicians, allied health, nursing and medical, and we were oversubscribed on the medical. We thought we might have to be wandering around tapping people on shoulders going, could you please come on the group because we do need your input. And they stood up. They said, you guys are on about the right thing, we want, now, you know, 6,500 staff, this is not perfect every day. I don't want to give anyone the impression that we've got this absolutely nailed. This is a long journey. But on the whole, the clinicians absolutely get that this is about the right stuff.
So the annual planning activity that we do, it is actually quite a big event. So there's 100 staff get brought in to the organisation for a day. We start with some sort of high level, this is where we are, this is how we're going. And then we sort of splinter off and we theme it into the strategic priority areas, but front and centre of that is best care as well. So we're constantly anchoring the message and we're constantly going back and translating that every day. The Best Care Training Plan actually was quite a milestone for us because it was one of those first sort of artefacts, if you like, that connected the dots for the frontline nurse, for instance. And I remember initially when we changed the sort of enrolment system and we changed our online learning platform and it was all Best Care and we were getting phone calls going, I don't understand this, what's happened to my CPR training, where's it gone? It's like, no. And so that was all part of our way of translating the message and educating the system about what we were doing. The waterboard dashboard, so of course we all love data and quality and we need to show how we're doing and I sort of joke with my team, of course, the meerkats of the organisation, you know, we're out there checking the signals in the system. And so we've been able to use technology somewhat to assist us in doing that. So we have transparency from local ward, knowing how you're doing boards, to ward electronic dashboards that then roll up into unit, divisional, right up to board. And certainly the Best Care report that I produce every second month to our Board Quality and Safety Committee is an aggregate of all of that information. But again, we've kept the patient voice clear and centre in that. So every Board Quality and Safety Committee starts with a patient story. And each of the Best Care Dimension Committees are responsible for delivering a patient story at least once a year, not just, it doesn't have to be just one, but the expectation is that they don't just tell the story, is that they see it through. So any recommendations that come out of that story around change actually goes into the system and becomes mainstream. The diagram in the middle is actually an interactive navigation tool that we've created online. One of the messages I heard when I first came into the role was, it's all about the committee, and we don't get it. We don't get the committee structure. We don't get what goes where. So we created this tool to, I guess, interpret and translate and help people navigate through the framework and connect it back to what was happening in their areas. So we're constantly working on this and hopefully we'll have some data in there soon so we can actually connect the committees to the work plan to the outcome. So people will actually start to connect the dots themselves. We release at a glance every time we have a steering committee or a Best Care Dimension Committee where we very simply say this is what we talked about, this is what we agreed. This gets sent out to all of the wards and units, goes up on the notice boards, on the knowing how they're doing boards. So we're constantly trying, I mean the communication is hard work, you know. There always seems to be a bit of a block, doesn't there, in the system, and it's like, how do you break through that floor? So this is one of the ways we've done that. So some of the things I think in hindsight, so you asked before about clinician engagement. So I think intuitively clinicians get this stuff, but I think it was really about connecting the dots for them and what's in it for me and my patients. So trying to keep them out of some of the process and the management bureaucracy, I think has been key, but also trying to get them to come along in the journey with us. Clarity of role and responsibility, this is something that I sort of keep coming back to in my current role, because it was really interesting. It was like, oh, well, the quality managers do quality, I manage care and I manage the money. So no, we all do quality. And we have to keep coming back to that. And, you know, really is about connectivity, and you can't do enough of that. And I really think we're well placed now with version 2 coming in 18 months or so. You know, the work we've done in person-centred care, for instance, sets us up beautifully for the comprehensive care standard. So we'll just naturally segue into that. We won't have to restructure everything because there's a new set of standards. So I think that's, you know, my biggest piece of advice is, you know, think about that. Don't let the standards drive you. You drive what you need to do for your service and your community, and the standards support that. And yeah, keep it simple, and if you keep it focused on the patient, you can't go wrong. So some of our achievements, so these are some of the signs and signals that we've seen, and we purposely put in a specific question around best care in our People Matters survey. That's our staff satisfaction survey that we run in Victoria. And this year, we were delighted to see that 92% of our staff understood how they contributed to best care. So I think that's really powerful. We have 6,500 staff, and we had a 42% response rate. So we're talking significant numbers. And across the patient safety questions that are standard in there, we were above the average. We also do our own internal surveys, and again, are specifically around the systems that support best care and how that was translating to our front line. And again, the signals are telling us we're going in the right direction. And we're also seeing that in terms of our external benchmarking, you know, our relative stay, our standardised mortality ratio, we're significantly below the benchmark and performing really well. And some of our internal clinical indicators are also telling us that we're making a difference. I guess the challenge is making that stick and making that happen every day, and that's something we still continue to work on. So I'm going to hand over to Alex now, who's going to sort of finish off around what we've learned and where we're heading.